Finally, we have a very distinguished speaker. So honored, really, to have Dr. Ru'a Abdel Jalil Khalifa with us today. She's a consultant cognitive and behavioral neurologist practicing at King Fahd Special Hospital in Dammam. She's E1 Cluster Residency Training Program Director, mashallah, Chairperson of Clinical Neurophysiology Department, Secretary General of Saudi Cognitive and Behavioral Neurology Chapter, and more, but because of the short of time, sorry, Dr. I cannot say it all. So, so honored to have you, Dr. Ru'a. Dr. Ru'a will speak to us about pharmacological management of cognitive dementia symptoms. تفضل يا دكتور.
Assalamu alaikum, good afternoon or good evening. Well, thank you all for staying around, staying with us this evening. Thank you, Dr. Hashim, for your warm introduction. And I would like also to thank the organizing committee for inviting me. It's quite hard to present after all of those marvelous speakers that have presented before me. But fortunately, they paved the way for my presentation because everything I'm going to say, they have already mentioned. So I'm going to sum up what they have mentioned. So I have no disclosures. So I think at this point, we're still telling patients that we don't have much to do for them, probably. Hopefully this is changing and is going to change further in the future. I'll skip this slide. So I was asked to speak about the pharmacological treatment of cognitive symptoms. And I would like to highlight that when we say cognitive symptoms, we mostly talk about memory because most of these studies that have done look into cognitive assessments like MMSE and MOCA as endpoints rather than other comprehensive cognitive assessments. So most of the medications that we prescribe, we mostly focus on memory symptoms. Cognitive rehabilitation, only one slide. So there is some evidence of cognitive rehabilitation, so not only pharmacological treatment, but also non-pharmacological treatment for cognitive symptoms, but maybe only for mild cognitive impairment and mild dementia, but not in the later stages of dementia. An example of that is Learning the Ropes for MCI in Baycrest, Toronto, where they teach patients with mild cognitive impairment how to overcome their difficulties. So you don't really expect improvement in MMSE, but you expect improvement in function, which is more important. I'll skip this slide. So these are the only few medications that are FDA approved and that we have available nowadays to treat Alzheimer's. It was first prescribed in 1996, was donepezil, then a few years later rivastigmine, few years later galantamine. These are the cholinesterase inhibitors. And then we have memantine that was approved 2004. And then, forgive me for the typo, and then 18 years later, 2022, aducanumab was approved, and then lecanemab was approved earlier this year. So I'll be talking about those medications. Now, I'll try to keep my talk as clinically oriented as possible. I'll go over this slide with some details. So the first three medications, donepezil, rivastigmine, galantamine, are the cholinesterase inhibitors. They're approved mostly for mild and moderate dementia. So sometimes you see them prescribed in mild cognitive impairment, that's off-labeled. And you may still see patients with severe dementia that are still receiving cholinesterase inhibitors, and we're going to talk about that. So usually, now what are the side effects that you're going to warn your patients? You're going to warn them about nausea, vomiting, vivid dreams, something we don't usually pay attention to. And sometimes if they develop vivid dreams, you may ask them what time of the day they receive the medication. You may move it earlier during the day. So it depends on, really there are no differences between the three of them. It depends on what you have available in your center. Then you have memantine, which is usually used as an add-on treatment, rarely used as a solo treatment in Alzheimer's, and it's usually introduced in the moderate to severe dementia. So then we have the combination treatment, vitamin E, we'll talk about it later. And then we have the two new medications, which my colleagues have talked about, previously, so aducanumab and lecanemab, monoclonal antibodies. And the main difference and the main change now is that we have some medications for mild cognitive impairment. We have medications for the earlier stages of the disease. However, we have to pay attention to the side effects, ARIA, amyloid imaging related changes. Now, it sounds as if it's a naive and benign thing and it's only an imaging abnormality, but it is actually a side effect with its cost, especially the hemorrhagic type. Now, management of Alzheimer's disease is an art. You need to, as always, we say avoid harm, and then you need to provide benefit and autonomy. Our main goal in managing Alzheimer's disease is to maintain and to maximize quality of life. And therefore, the first step, as mentioned by Dr. Hisham, is to go over their treatments and clean their treatments. That's probably sometimes even more helpful than introducing new medications. Benzos, antipsychotics, antidepressants, antihistamines. So you'll be surprised when you go over the over-counter medications they receive. So it's not only the prescribed medications, but also the over-counter medications that you need to clean first. See if they really need it, see what change they can do. Always make one change at a time. So I'll start with this example case, and then we'll go over different types of approaches and treatment. So this is Mrs. Noura. She's 66-year-old. She's a female, and she presented at a cognitive neurology clinic with 1-year history of being more forgetful. She's known to have hypertension. She thinks it's under control. She's a business owner, and she runs her own business without any difficulty. She's a college graduate and has no family history of any neurodegenerative disease. Her blood pressure is 140/90, her neurological exam is normal, and her MMSE is 30 out of 30. Her MRI brain is normal, so no white matter changes, no atrophy. Now, at this stage, what would you call this, and what are you going to do? So for the sake of time, I'll jump. So at this stage, we call this subjective cognitive decline. We're talking about someone who's reporting forgetfulness, yet we don't see evidence of memory changes or cognitive impairment on testing, and they're completely functioning. She's even running her own business, paying her own bills. So at this stage, I would just encourage lifestyle modification and treat her hypertension. If she's already tried lifestyle modification, I may start treatment. A year later, she came for follow-up, and she reports worsening of her symptoms. She's still independent, she's still running her own business, but now her MMSE shows some decline. Now she scores 27 out of 30, she lost 3 points in recall. You're not sure, you bring her for a follow-up in 6 months, and she reports further decline, and she now lost 4 points in MMSE, 3 in recall, and 1 in orientation. What would you call this at this stage? So at this stage, you would call this mild cognitive impairment because she reports symptoms and you see evidence on testing. Now, I'm simplifying this with MMSE. You may need to do more comprehensive testing, but let's just keep it as simple as this for now. So what would you do at this stage? Someone with mild cognitive impairment. You may still encourage lifestyle modification. Do you want to add vitamin E? Do you want to order amyloid PET or CSF amyloid? Or do you want to start cholinesterase inhibitors, doing that off-label? Now, apart from the vitamin E, maybe all of this is correct. You still need to encourage lifestyle modification. You can order amyloid PET because you want to start aducanumab or lecanemab. You can start cholinesterase inhibitors as off-label. But the usual practice and the current practice is still to encourage lifestyle modification and continue with lifestyle modification. And we'll see later if we have other options for Mrs. Noura. Vitamin E, there is no role for vitamin E in mild cognitive impairment, unlike severe dementia, as we'll mention later. So a year later, Mrs. Noura came with worsening of her symptoms, worsening of her MMSE. Now she needs some help managing her business. She needs some help paying her bills. So at this stage, as mentioned earlier, you are at the stage of mild dementia, when some of the daily functions that require high intellection the patient needs help with. So you are at the stage of mild dementia. So you need to set some realistic expectations with your patients. or their caregivers. It's very important for them to understand that if the patient is starting at point A, 3 or 5 or 6 years from now, they're going to be at point B, regardless of whether you're going to start the treatment or not. However, the quality of life, the function, their everyday activity differs when they start treatment. So it's very important to explain this. People think that prescribing medications delay the disease progression. It doesn't, but it delays the clinical progression of the disease. Their brain is going to continue shrinking, and their amyloid is going to continue depositing. Now, all of the studies, we have enough evidence that starting cognitive enhancers is good for cognitive function and quality of life and everyday function on the long run. So this is a systematic review looking into the start of acetylcholinesterase inhibitors and memantine for dementia. These are the studies now looking into monotherapy, and you can see that regardless of the medication, whether it's donepezil, galantamine, or rivastigmine, they all favor the outcome, and they all can improve MMSE over a period of 6 months to 12 months, 6 to 12 months by 1 to 2 points. Memantine monotherapy is also effective. However, it's less effective than cholinesterase inhibitors. Type, do we start now? Isn't it too early? She's just mild. It's just that her business that she's unable to run. But studies have shown that starting early is better than starting late. So if you look at the graph here, and here they're looking into rivastigmine, and we'll see this is replicated with donepezil and galantamine. So if you see starting early with high dose, comparison to placebo is better. And then those who were on placebo and then started on higher doses of treatment did pick up and did improve and did do better than if they continued with the natural history of the disease, yet they still did not pick up to those who were started on a higher dose from the beginning. So it's always advised to start early. Go to the higher dose if the patient can tolerate. So again, same thing was reproduced with galantamine and donepezil. So going back to Mrs. Noura, she came again to the clinic a year later with worsening of her symptoms and worsening of her MMSE. Now she started to need some help at home, doing the laundry, cooking, using appliances. So at this stage, I would say she's at a stage of moderate dementia. And what I would do is I would add memantine. So she was started on cholinesterase inhibitors. Then at this point, you can add memantine. And again, studies have shown that adding memantine to donepezil, and you can use the same analogy with the other cholinesterase inhibitors, is better than continuing on cholinesterase inhibitors alone. Now she came again a year later with clinical deterioration, significant worsening in basic ADLs. Now she needs help bathing, combing her hair. She's unable to use utensils and so on. So now she's at the stage of severe dementia. Do we stop cognitive enhancers? She's already advanced. She already needs help with ADLs and basic ADLs. So shall we stop them? So studies have shown and evidence supports against stopping treatment if there are no side effects. So if your patient is doing well on the medication, you don't see medication side effect, they will continue to decline, but you don't see medication side effect, it's always advised to continue treatment, because it was shown that stopping treatment later on can affect behavioral and functional outcome, probably not cognitive outcome. So the conclusion is the persistent use of anti-dementia drugs can reduce the clinical progression of Alzheimer's disease. So as I mentioned, vitamin E, in addition to other cognitive enhancers, in the moderate and severe stages of dementia can be helpful, but not in the stage of mild cognitive impairment and mild dementia. Is there another scenario for Mrs. Noura? Can we do something else with her? So with the current advances, with the immunotherapies that we have now, yes, you may choose to go for PET scan, CSF amyloid, proved that it is Alzheimer's disease and proceed with immunotherapy, aducanumab or lecanemab. I will not go through these slides since they were mentioned before, but I'll just say that this is our current, or at least until now, our current understanding of Alzheimer's disease. We look at Alzheimer's disease as a tauopathy, as Dr. Taim mentioned. It's a disease in which tau starts depositing together with amyloid, and then later on you start seeing decline in function, a shrinkage in the size of the brain, and then you see cognitive decline, functional decline, and frank dementia. This is our understanding of Alzheimer's disease. This is what we've understood for years. However, a decade of studies have shown that it's probably not entirely correct. It's probably not entirely accurate. So several studies, as you know, proved that this is not 100% true. So these are medications that were absolutely perfect in removing amyloid from the brain, yet patients did not improve, or even surprisingly, people declined. So subjects on those studies got worse when amyloid was removed. So we should not reject data merely because we do not like what the data implies. Yet, despite this one decade of negative trials, aducanumab was approved last year, June 2021. So aducanumab is a monoclonal antibody. Dr. Haytham talked about it briefly. So it works on removing amyloid from the brain. So it's a monoclonal antibody that binds to amyloid and remove it from the brain. Based on these two studies, EMERGE and ENGAGE, as you can see, both studies showed that aducanumab was successful in removing amyloid from the brain. However, the ENGAGE study was a negative trial in which they did not meet the primary endpoint. Patients did not improve on CDR sum of boxes. However, on the EMERGE trial, and based on this trial, the medication was approved. They did see less than 0.5 improvement in CDR sum of boxes. Now, this is the CDR sum of boxes, which is an activities of daily living assessment tool. And as you can see here, you can move from moderate dementia to severe dementia by an improvement of 0.5. While aducanumab did not, if you prescribe aducanumab, you can't push the patient from the moderate stage to the advanced stage. Is this a meaningful improvement? Is this a meaningful outcome? That's a question. So I'll skip this slide. So we had a statement in the chapter about aducanumab. You can read it in the website that I'm going to put at the end. And then lecanemab came. So lecanemab approval was earlier this year on January 6th. And again, it's a monoclonal antibody that removes amyloid from the brain. The difference between lecanemab and aducanumab is that the improvement was somehow meaningful. So it was more than 0.5 in the CDR sum of boxes. And that's why people were more optimistic with lecanemab than aducanumab. But now the question is this change meaningful? Now, as physicians, we think 0.5 improvement in CDR sum of boxes is not meaningful. You're barely moving a patient from moderate stage of dementia to, from severe to moderate stage of dementia. But would patients and family and caregivers say the same? Probably they have different views. Probably they have different perspective. Is this change sustainable? Now, we have those studies followed patients for 18 months, and we know Alzheimer's disease is a disease that you need to follow for a longer period of time to make a judgment out of it. So would following those patients for 5 years show a bigger divergence between the two lines? We don't know. So this is another, now, do we really want patients with, for example, if I was a physician, I may say, I don't want to prescribe a medication that makes my patient with moderate dementia still demented a year from now. But if I was a caregiver, I may say, if this medication is going to keep my beloved one able to feed themselves a year from now, I want it. I want them to feed themselves a year from now. I don't want to feed them. I don't want them to have a PEG tube. So we need to probably involve patients and caregiver in understanding those data and those outcomes. Is it cost effective? Again, it depends on how you see it and how you think you should put your money or where you should put your money. Now, then after all of this, is the amyloid theory still alive? I think personally, it's probably, we still haven't got the last nail in the coffin of the amyloid theory. I think there is still some life in the amyloid theory, but I think we need to understand it differently from a different perspective. As you can see here, you cannot diagnose Alzheimer's without amyloid. Then it has to be there for a reason. Or maybe it's there for no reason. And this is what we need to understand more and to look at into more depth. Are aducanumab or lecanemab an option for Mrs. Nora? I think at this stage, we don't know, maybe not. This is our statement, and I would quote this statement to answer this question. We still need a lot of work to have those medications available in the kingdom. We need to know the extent of the disease in our country. We need to have the biomarkers available to diagnose them. We need to have the normative assessment tools to assess their cognitive functions and to assess their functional decline or their functional capabilities. We need to have multidisciplinary centers with clinics that are well collaborated. We need to have readily access MRI machine for those patients whenever they develop any deterioration. You can't prescribe MRI, or you can't request MRI and wait for an MRI to be done a month or 2 months from now. You need to have easy access to MRI. So many medications are still in the pipe and we're still waiting for them. I'll skip those. Okay, so this is our group in the Saudi Cognitive and Behavioral Neurology chapter. This is our Twitter account, and this is the website. We're under the umbrella of the Saudi Neurology Society. And as Dr. Haytham mentioned, we're open to work and collaboration with all other specialties and societies. We believe that it takes a village. We can't do this alone. We need all of you to be with us. We need other physicians, other specialties, and we need patients and caregivers to continue with our journey. Thank you for having me today, and thank you for being here until this time. Thank you.